Whereas on the flip side, individuals who have very large Kringle 4 repeats, have a very high number of them, may have a lower overall mass of Lp(a). So it's predominantly genetically determined from birth. There are some other factors that come into play that I'll mention that can also have an influence. But part of the reason why I'm mentioning this difference in Kringle 4 repeats is because there are different ways to measure Lp(a). So some of you might be measuring this in your clinical practice. And there are two different ways you can measure it. You can measure either the milligrams per deciliter, so its mass, or you can measure its molar concentration in nanomoles per liter. But as you can see, if you look on the left-hand side, you can have the same number of particles, but with a variable mass, depending on, again, the number of Kringle 4 repeats that might exist for that individual. On the flip side, you might have a different number of particles, but with very similar masses, just by virtue, again, of the number of Kringle 4 repeats. So which one matters more? Overall, that the feeling is that the number of particles, so really a molar assessment, is probably the preferred way to measure Lp(a). And many of the assays are sort of shifting in this direction because, again, the number of repeats itself is not what appears to really kind of carry the risk, but rather the number of particles being the key differentiating factor. Sometimes I'll get questions from people where they say, well, how do I convert milligrams per deciliter to nanomoles per liter? And you can't. That is functionally one of the challenges. And again, it has to do with this variable size of apolipoprotein(a). So I've mentioned that genetics predominantly control Lp(a) concentrations. Some estimates say that more than 90% really of Lp(a) is genetically determined. But there are some non-genetic factors that may influence Lp(a) as well. We know that it can go up with chronic kidney disease, might go down with liver disease. Also, just of note, even though usually they're fairly consistent in somebody's life, we know that around the time of menopause, that Lp(a) concentrations do often rise for women. And there has been some thought that this might be part of the uptick in risk that is observed for women after their menopausal transition. It's also somewhat of an acute phase reactant. So we know that there can be a transient blip, so to speak, in Lp(a) in the acute inflammatory setting. But one of the important things is that lifestyle changes do not really appear to have a profound impact. So typically when you're managing your patient who might have high LDL cholesterol, for instance, usually you'll say, okay, well, let's, work on your diet and work on exercise. But unfortunately, in the situation of Lp(a), it doesn't appear to have a very large impact on its concentration. There are also marked differences by both race and ethnicity that have been described. We know that in Black individuals, the levels are quite substantially higher. And again, this appears to be predominantly genetically determined. And understanding that, of course, Black individuals for different populations, some are self-reported and may not be correctly categorized. But rather just to describe, though, that if you look at the right-hand side of this figure that I'm showing, you can see that in white individuals, it's been described that Lp(a) is heavily skewed. So you can see that most people are clustered down towards very low levels of Lp(a), but there's a very long tail to the right, showing that some individuals really have very high levels. If you look at Black individuals, you can see that there isn't as much of a clear skew to the distribution. It does still remain skewed, of course, where there are some individuals who have very, very high levels. But overall, there's definitely quite a marked shift rightward. In fact, if you look at the median concentration in white individuals across these populations that have been described here, the median value is 19 nanomoles per liter in white individuals versus 75 nanomoles per liter in Black individuals. Individuals of South Asian descent have also been described to have higher Lp(a) levels as well. Whereas we believe that largely in Chinese and Japanese individuals that the levels tend to be overall lower. But focusing, I suppose, on this sort of skewed distribution, one observation that has been made is that for those individuals with established atherosclerotic cardiovascular disease, shown here on the right-hand panel, that there is a right shifting of this distribution. So that might be expected, because as we'll talk about, Lp(a) is associated with the risk of cardiovascular events. And so one might expect, therefore, that those individuals with established atherosclerotic disease might on average have higher levels. So I mentioned that it was first described, Lp(a) was first described in 1963, but it wasn't really until the 1990s that there was particular attention paid to the fact that higher levels of Lp(a) were significantly associated with an increased risk of myocardial infarction, as well as other types of cardiovascular events. So these were data that were published by Paul Ridker in JAMA in 1993 from the Physician Health Study, basically describing that relationship. Higher levels spelling a higher risk of myocardial infarction. And since that time, there's really been a large body of evidence, a large number of epidemiologic studies to show that there's, broadly speaking, a log linear relationship between Lp(a) and risk of non-fatal MI and coronary death, a relationship also with ischemic stroke, but that relationship is flat for non-vascular death, as we might expect, if we think that this is predominantly a marker of increased risk of cardiovascular events. And specifically, I've talked about both myocardial infarction and ischemic stroke, although the relationship appears to be there for ischemic stroke as well. By and large, the strongest relationship is between Lp(a) and risk of myocardial infarction and coronary heart disease death. Notably, though, if you look on the bottom right side of this figure, there is an interesting relationship that has also been described between Lp(a) and aortic valve disease. So that has been very intriguing, because as we'll talk about later, right now there are not a lot of options that we have in terms of available therapeutics to change Lp(a) concentration. But there's this intriguing idea that with these therapies that are now in development, might we eventually have something that might be able to halt progression of aortic valve disease? And that's been very exciting, because as you know, right now we really don't have any therapies that are able to modify that trajectory. So I had described the differences between white and Black individuals in terms of Lp(a) concentrations and what we see for the distribution in a given population. But it is interesting to note, though, that the relationship between Lp(a) and risk of MI, stroke, or coronary vascularization is very consistent, regardless of race. And I'm showing here the relationship for white and Black individuals. But even though you're right shifted, very often for looking at the distribution in a predominantly Black population, we know, though, that the magnitude of the increase in risk start at those same very low levels that we see for white individuals. So, being part of the puzzle, or perhaps risk that's not being adequately modified for individuals of different race or ethnic backgrounds, if Lp(a) is part of the story. Well, what about, mostly I've been describing primary prevention setting. We had published some work, though, looking at Lp(a) and cardiovascular risk in those with established atherosclerotic disease. There, the relationship has been a little bit less predictable, perhaps speaking to the fact that once you already have cardiovascular disease, that Lp(a) may not necessarily be able to further distinguish those who are going on to have cardiovascular events. But again, the data have been quite mixed. We had done some work suggesting that perhaps some of this was explained by LDL cholesterol. And so for those individuals with well-controlled LDL cholesterol, that perhaps that was helping to attenuate some of the increase in risk that might be seen with higher Lp(a) concentrations. But there have been other published data. This is a patient-level meta-analysis looking at secondary prevention patients and showing that the magnitude of the relationship between Lp(a) and cardiovascular events is consistent, really, regardless of statin use. Well, we've focused mostly so far on talking about the epidemiologic data that might suggest that Lp(a) plays a causal role in atherosclerotic disease. But, there's a growing amount of evidence to really support the concept that it plays a causal role. What I'm showing here are just some histology slides, and these are quite interesting. What the brown is staining for is the presence of apolipoprotein a. So again, a key component of lipoprotein a. And as you move across different figures, what you're seeing is sort of a progression of an atherosclerotic plaque, so becoming increasingly unstable. And you can appreciate immediately that there's more intense brown staining for those plaques that are deemed the most unstable. And what's interesting is that really the brown staining might comprise up to about a third of the entire area of that plaque. But if you stain, for instance, for apolipoprotein B, so ApoB, which is classic for LDL cholesterol, it's actually a very small component of what you see within that plaque. So it's intriguing data to support that the relationship between Lp(a) and plaque instability may be quite strong. These are also some data that were published in the Journal of the American College of Cardiology earlier this year. And what they did was they took individuals who had the same amount of atherosclerotic disease in their coronary arteries at baseline. And they did a coronary CTA at baseline and then followed it up 12 months later with a subsequent coronary CTA. And what they found was that those individuals who had high Lp(a) concentrations really had accelerated progression of low attenuation plaque, independent of traditional cardiovascular risk factors. In contrast, those who had lower Lp(a) concentrations, their plaque volume did not appear to be progressing as rapidly. But perhaps the most compelling data is that there have been a growing number of Mendelian randomization studies. So really supporting the concept that those who have genetically predicted high Lp(a) concentrations are at higher risk of coronary heart disease. This has now been shown across many different populations and have been independently validated. So I think really, has provided perhaps the most robust evidence that indeed Lp(a) plays a causal role in terms of atherosclerotic disease progression. What's interesting, though, there has been a lot of interest in whether or not Lp(a) may play a role in thrombosis as well. I had mentioned at the beginning that homology that it has with plasminogen, but it's not supported by the Mendelian randomization data. So genetically predicted Lp(a) concentrations do not appear to predict risk of venous thromboembolic events, even though some relationships have been described in the literature. But by and large, the feeling now is that Lp(a) might not increase risk of thrombosis. And I had mentioned, though, also this intriguing relationship between Lp(a) and aortic valve disease. So this is a Manhattan plot looking at SNPs that predict risk of aortic valve calcification. And you can appreciate here that the Lp(a) gene being the outlier in terms of showing that relationship with aortic valve calcium. So relationship's been described both aortic stenosis as well as need for aortic valve replacement. There have been questions, though, about what point along the causal pathway Lp(a) may be involved with progression of aortic valve disease. This was one study that got a lot of attention earlier this year, suggesting that Lp(a) might be associated with the onset of aortic valve disease. So basically showing a relationship between Lp(a) and extent of calcification of the aortic valve, but then over long-term follow-up, not necessarily being associated with the progression of aortic valve calcification. What implications does that have? Well, I think for one, it tells us there's still a lot we don't understand about the progression of aortic valve disease, but it might ultimately have some implications if these newer therapies that are in development ultimately show a benefit in terms of modifying the course of aortic valve disease. One thing that's also been described, and it's relevant as we think about some of these therapies that are now being designed that markedly lower Lp(a) values, is that it has been described along the way that very, very low Lp(a) concentrations are associated with higher risk of diabetes. These were data that were published by Samyamura back in 2010 from the Women's Health Study. Appreciate it's hard to see the different colors here, but quintile 5 being the highest curve there, showing an increased risk of diabetes. And then in a consensus document that was recently published, they did conducted a meta-analysis as well, again suggesting that those with the lowest levels of Lp(a) may be at higher risk of diabetes. So somewhat akin, many of you are likely familiar with the fact that statin therapy has been described as potentially increasing risk of diabetes. This is interesting, that very low levels of Lp(a) might also be associated with risk of diabetes. And this has been supported by some Mendelian randomization data as well. We described this also within the Fourier study. So Fourier was a study of one of the PCSK9 inhibitors, but just looking at the relationship between Lp(a) in that population and either prevalent or incident diabetes, we again saw a similar relationship where lower levels of Lp(a) were associated, in fact, with an increased risk of developing or having diabetes. So I had mentioned a consensus document that had been published just earlier, I'm saying this year, but I mean last year, 2022. So this was the European Society of Cardiology and the European Atherosclerosis Society that worked on this document to really outline what we've now understood about Lp(a) and risk. And it is quite nice. It's a very helpful document if you are looking for a reference, and it's been published in your European Heart Journal now. But basically showing that the lifetime risk of atherosclerotic cardiovascular disease is really quite markedly stratified by your Lp(a) concentration. So again, we expect those concentrations to be largely fixed from birth. And then you can appreciate that around the age of 50, there's really quite a marked splay. Whereas for those individuals with the highest levels, that their lifetime risk of ASCVD might be upward of 40%. Whereas those with the lowest levels, which is actually right around the population median, might have a lifetime risk that's really closer to about 10%. So in this consensus document, they sort of walk you through this idea of whether or not Lp(a) could be used as an additional tool to really help guide risk stratification for different individuals. So as you move from left to right in this figure, it's looking at your baseline risk of ASCVD calculated using, obviously there are different types of lifetime risk estimating algorithms, but very few of them currently incorporate Lp(a). So you can appreciate that as you now take whatever that score is, whatever your baseline risk of ASCVD might be based on any of these calculation tools. And as you move from front to back, now incorporating Lp(a) into that algorithm, how a substantial number of people really get pushed into different bins. And so functionally, reclassification has been described to be quite striking when Lp(a) is taken into account with some of these lifetime risk assessment tools. So if you currently have a patient who has high Lp(a), you might then be saying, well, what on earth am I supposed to do with that information? Many of these recommendations now support measuring Lp(a) at least once in somebody's lifetime. But how do you then attenuate that risk? And that has been the real challenge. Of course, our go-to for many years has been to give people statin therapies when we think that they're at increased risk of cardiovascular events. But statins, if anything, raise Lp(a) concentration. So that presents a real conundrum because we don't really have a handle on whether or not statins may in fact attenuate any of the risk that is seen with higher levels of Lp(a). Nicotinic acid, niacin, has been described as one option, but we know that based on phase 3 trials, that doesn't appear to reduce cardiovascular risk. PCSK9 inhibitors, and I'll describe that a little bit more in the upcoming slides, have presented a new option because in contrast to statin therapy, PCSK9 inhibitors lower LDL cholesterol and also lower Lp(a). The last line on this table too is showing you that there is an option for apheresis. This is something that's done typically for people who have extremely high LDL cholesterol concentrations. It's not something that's very frequently employed in the US, but is more frequently employed in different places in Europe. But it is an option for lowering Lp(a). But of course, we really have a lack of data to support that doing this actually translates into better outcomes. So I'd mentioned the data with PCSK9 inhibitors. These were some data from Fourier that we had published looking at the median percent change in Lp(a) with evolocumab. I'm showing on average that it was dropped by about roughly 27%. And then the median absolute change was about 11 nanomoles per liter. So overall, that's a relatively small change. At first blush, 27% sounds like a decent amount, but 11 nanomoles per liter, isn't a very large absolute reduction in Lp(a). So it's unclear if that's going to be sufficient to translate into improved outcomes. We looked at also the median percent change in Lp(a) based on baseline Lp(a) concentration. It has been described across a few different populations that those individuals who have higher baseline Lp(a) concentrations might actually have a smaller percent change. Fortunately, overall, if you look on the right-hand side of this figure, it shows that you still have a larger absolute change if you have higher baseline levels. Obviously, just by virtue of the fact that you might be at a very high starting point. But if you're somebody who has a baseline Lp(a) of 200, getting a drop of about 36 nanomoles per liter is not a very large amount. So it really kind of begs still the question of would more powerful therapeutics lead to more meaningful changes? And there's also a fair amount of inter-individual variability in terms of the response to evolocumab for Lp(a) lowering. This is looking at the percent change in Lp(a) for those patients on evolocumab along the x-axis. And some people had a very large change. Some people had, really a very small change or even a rise. So really kind of highlighting that PCSK9 inhibitors do not appear to offer a complete solution to the problem. What's interesting, though, is, I made the point that statins don't lower Lp(a). PCSK9 inhibitors do. What this is looking at is the correlation between percent change in Lp(a) and the percent change in LDL cholesterol. And you can appreciate that it's really pretty modest at best. So it's interesting that the two are not necessarily going hand in hand. So it doesn't appear that one really goes along with the other for the ride. And some of the mechanism by which PCSK9 inhibitors might influence Lp(a) is actually one that remains understudied. So it doesn't remain completely understood. But one question that was also raised was, well, should Lp(a), be helping to identify those individuals who derive greater benefit, perhaps from PCSK9 inhibitors? As we know, PCSK9 inhibitors are relatively expensive. You might not be able to get easy coverage for them. But, when we looked at those individuals with higher Lp(a) concentration, which is shown on the right-hand side, the red bar being PCSK9 inhibitor, the blue being placebo-treated patients, those individuals were at higher risk of coronary events, but also they appeared to have a larger absolute risk reduction with PCSK9 inhibition. So the number needed to prevent one major adverse cardiovascular event was 36, as compared to 79 for those individuals with lower levels of Lp(a). So it's just one consideration that's been put out there. Another consideration that's been thrown around is the idea of sort of achieving dual goals. You know, should we not just be thinking about LDL cholesterol as a target, but, you know, also achieving lower levels of Lp(a)? So this figure is showing that those individuals who have low Lp(a) and low LDL cholesterol are at lowest risk of cardiovascular events. Whereas if you have elevation of either one, that does confer about equivalent risk. So whether your LDL is high or your Lp(a) is high, again, your risk is somewhat on a level playing field. So again, turns to some of these therapies that are now being developed to lower Lp(a). What are other strategies that we might have? You know, so people are often asking me, well, should I give aspirin to my patient who is just, you know, has high Lp(a) levels, but they've got no known cardiovascular disease? Well, it was thrown out there as an idea by a few different groups. This is some data from the Women's Health Study that showed that genetically predicted Lp(a), that those individuals who were carriers of this one particular variant that conferred higher levels of Lp(a) concentration, that if you were treated with aspirin in that scenario, that appeared to attenuate the risk that was seen with higher levels. This was supported by some data that was published last year from the ESPRI study. Again, looking at similar SNPs, so similar genetic variants that conferred higher Lp(a) concentrations, and again, suggesting that those who were on aspirin, that risk might be in part attenuated. But overall, the feeling is that the data are not yet robust enough to support aspirin as a way to attenuate risk for higher Lp(a) concentration in a primary prevention population. So that's not a strategy that is currently endorsed. In part two, even within this ESPRI study that was published, when they looked at a different type of genetic score to predict Lp(a) concentration, that same relationship was not described. You know, so it might suggest that this is in fact just a spurious signal, and we're still looking for the right approach to attenuate risk for those individuals with high levels. So I guess one question that really is important is how much lowering of Lp(a) do we really need to see in order for that to translate into a meaningful clinical benefit? What this is showing are some data based on Mendelian randomization data. So this is data from Brian Ferentz published in JAMA Cardiology in 2018. And basically what it's saying is that, well, on the left-hand side, we know that about a 1 millimolar, you know, roughly about a 40 milligram per deciliter drop in LDL cholesterol translates into about a 22% reduction in coronary heart disease risk. That reduction might be even greater, in fact, for those individuals who have lifelong low levels of LDL cholesterol. So how much of a drop in Lp(a) might we need to see in order to see the same type of benefit? And many different studies have now tried to sort of zero in on that question. This was one study that got a lot of attention because it suggested that you might really need to have about 100 milligram per deciliter drop in Lp(a). That is a very large amount. So that's a pretty whopping reduction in Lp(a) that you would need to see in order to have that translate into a 22% reduction in coronary heart disease risk. And there have since then been a variety of different genetic estimates. So again, based on Mendelian randomization data, ranging anywhere from about 66 to 101 milligram per deciliter. But you'll recall when we looked at the Fourier data, what we saw as an absolute drop was much smaller with evolocumab. So I think, again, just really emphasizing the concept that the genetic data suggests that we need to find therapies that have a huge effect on Lp(a) in order for that to be ultimately meaningful. So to that end, where do we stand now? There are different therapies that are in development that are overall quite encouraging. These are some data that were published in the New England Journal in 2020. is a drug named pelacarsen, which is an antisense oligonucleotide against apolipoprotein a. And it's a subcutaneous injection. And you can see here on the left and the right the effects on Lp(a). So they showed that at the highest doses of pelacarsen, that there was somewhere between a 70 to 80% reduction in Lp(a). And this was studied in individuals with established ASCVD and elevated Lp(a) concentrations at baseline. That particular drug, pelacarsen, has now moved into phase 3 testing. In fact, enrollment is now complete. And they enrolled just shy of 8,000 patients, and they expect results in 2025. And they enrolled patients with MI or ischemic stroke, as well as symptomatic PAD, who had high Lp(a) concentrations, so levels of at least 70 milligrams per deciliter. And they're going to be looking to see whether or not that translates into a significant reduction in cardiovascular events. We recently looked at olpasiran. I just have a little figure here just to highlight how olpasiran works. For those of you who might be less familiar with small interfering RNA, so olpasiran is a type of siRNA that gets brought to the hepatocyte through its GalNAc moiety. And then once inside the liver, the antisense strand is loaded onto what's called the RISC complex. That RISC complex then ends up binding to the mRNA for apolipoprotein a, and that RISC complex basically targets it for destruction. So what you end up having is the mRNA that is ultimately destined to encode apolipoprotein a, which is again the key component of Lp(a), and then that prevents really from the assembly of Lp(a) because that apo(a) component is not being synthesized. So we recently presented the results of Oceana-Dose. This was the phase 2 study for olpasiran. These were individuals with atherosclerotic disease and elevated Lp(a) concentrations randomized to one of 4 doses. One of the nice things about the small interfering RNA platform is that it allows for less frequent dosing. So with pelacarsen, it was being dosed every 2 or 4 weeks in the phase 2 program, and it's being dosed every 4 weeks in the phase 3. But olpasiran can be dosed every 12 weeks. In fact, there was one exploratory dose that was administered every 24 weeks. And if we look at the percent change in Lp(a) from baseline through to 36 weeks. So you can appreciate that with increasing doses of olpasiran, that there was a really marked and sustained reduction in Lp(a) that was maintained with this every 12-week dosing interval. With the every 24-week dosing, there you can see that there's a little bit more fluctuation, but nonetheless still a quite marked reduction in Lp(a) that was observed. In fact, when you look at the placebo-adjusted reductions, they're really quite remarkable. People have been joking on this end that it's not often that you see more than 100% reduction in Lp(a), which you can see was seen at the higher doses here of olpasiran. That's again because it was a placebo-adjusted value. And in the placebo arm, there was a slight upwards drift in Lp(a). So when you compare the olpasiran values to placebo, it leads to slightly more than 100% reduction. But suffice it to say that, that it's really quite an impressive drop that was observed. And at the higher doses, so namely looking at the 75 milligram or 225 milligram doses, there was very limited interpatient variability. In fact, if you look at the distribution of Lp(a) concentrations in the placebo arm, you can see here scattered along in purple. And then you look at those individuals on the higher doses of olpasiran, you can really see that even though people started at the same point, as reflected here with the placebo group, there was just a marked downward shift in Lp(a) concentrations at that achieved time point of 36 weeks. Of interest, olpasiran also has an effect on LDL cholesterol. This has been described with the other therapeutics in this class that are in development as well. So there's a drop in LDL cholesterol, a drop in apolipoprotein B. Some of that appears to be explained just by virtue of the fact that Lp(a) is dropping. You'll recall that I mentioned that LDL cholesterol is part of Lp(a). It's part of that molecule. So by lowering one, you end up lowering the other. But this is still being explored to better understand the nature of that relationship. Granted, this was just a phase 2 study, so relatively smaller in size, but nonetheless, it appeared overall to be safe. I had mentioned diabetes concerns at very low levels of Lp(a). This was not seen in the phase 2 program. We didn't see any uptick in diabetes risk with the higher doses of olpasiran. That being said, again, these are small numbers and really will need to be explored further in phase 3. We did see an uptick in injection site reactions and hypersensitivity reactions. Again, those hypersensitivity reactions were surrounding the injection site. So, you know, and those were expected. But again, I think the phase 3 program will be important to better understand. So to that end, the Oceanic Outcomes study is now underway. This is a trial that we're leading at TIMI in collaboration with Amgen. These are individuals with established ASCVD, either prior MI or high risk prior PCI with high Lp(a) concentrations greater than 200 nanomoles per liter. And they're being randomized to olpasiran or placebo every 12 weeks and followed for a median follow-up of 3.5 years. So we just enrolled our first patient last month. So we're delighted that trial is now underway. I'll also just mention that there is another small interfering RNA as well. The phase 1 results were presented last year. And this was a single ascending dose study with only 32 patients, but again, showing, you know, what appears to be somewhere between 80 to 100% reduction in Lp(a). So there are really a lot of exciting therapeutics that are in development. So, you know, bottom line, what do you do today? How do you manage your patient with high Lp(a) concentrations? This was the current recommendations in that EAS document that I mentioned that's now published in the European Heart Journal. Basically trying to help break down for you, you know, what kind of strategies might be reasonable. In general, the focus, if you are going to turn to drug therapy, is still just towards traditional risk factor modification. So in terms of LDL cholesterol, blood pressure, glucose control, right now there's insufficient evidence to really support aspirin use. And we don't know for sure whether or not using a PCSK9 inhibitor is better than using a statin, for instance. So there's more research being done to better understand that relationship. So just in summary, we now have a fairly robust evidence base to support a causal role for Lp(a) in coronary heart disease risk. But it really remains unknown how large of an absolute drop might be required to see meaningful clinical benefit. But fortunately, we now have these Lp(a) lowering therapeutics that lead to very marked reductions, and they might be able to better really kind of directly test that hypothesis. So until those therapies are available, you know, traditional risk factor mitigation is really what's recommended for higher risk individuals with high Lp(a). But really, ultimately, there's a lot of enthusiasm for some of these therapeutics that are now in development. So I'll stop there and see what questions you might have. Thank you.
Great. Well, Dr. O'Donoghue, thank you so much for a really phenomenal talk, so clear and on an important topic that I think many of us don't know about as regularly, but I think have been hearing about. So again, just a reminder to people who join late that you know, today's conference is a joint session with the GW Biomedical Cross-disciplinary Seminar Series. And thank you, Dr. Frame, for your partnership and inviting Dr. O'Donoghue. Feel free to put questions in the chat or raise your hand if any questions. And Dr. Donahue, I'll sort of lead off and just say congratulations on the Ocean dose study. That's really fantastic and impressive results, and excited to see the outcomes. And so a question for you is around the risk associated with Lp(a) at the highest levels, and whether we see similar risk at low levels of LP elevation as we do at the highest levels. And I noticed that for the outcomes trial, you increased the threshold from 150 nanomoles per liter up to 200. And that may just be a study design as an outcomes trial. But I wanted to get your thoughts on kind of the risk of Lp(a) at low levels of elevation versus the highest levels of elevation.
Yeah, no, it's a great question, because as you saw in some of those early slides that I showed, it's not like there's a clear threshold in risk, right? So, some people have said, okay, well, we'll declare an abnormal level to be about 50 milligrams per deciliter, which is roughly, somewhere around 125 nanomoles per liter. The problem with that, though, is that, it's not like people below that are clearly at much lower risk than those who are above. It's really kind of a more log linear relationship that we see. And so that's been one area of controversy is, what do you describe as an abnormal level? Part two to what you're asking, though, is, why are we picking such a high threshold for entry into these phase 3 programs? Because ultimately, if you were sort of thinking back to the early slides at where that distribution curve sort of points to the 200 nanomole per liter level being, it actually is about the 85th percentile. So only about 15% of individuals would be expected to qualify for instance, our phase 3 program, just based on Lp(a) concentration alone, which is challenging, and ultimately that's, one of the things that we, tried to push back with with Amgen. We were hoping to actually have an even broader patient population. But the reason that it was selected to be so high is because of that, those Mendelian randomization studies that I showed you, where it looks like you might need to have upward of 100 milligram per deciliter, which is like about a 225 nanomole per liter drop, in order for that to translate into meaningful clinical benefit. Ultimately, a lot of people feel like you probably don't need that large of a drop. But if there's a chance that you do, the feeling is, okay, well, with the first round of these studies, we'll start with people with super high levels so we can demonstrate benefit. And it's just kind of like with the statin trials, right? Originally, they only studied people with super high cholesterol levels. And then now as the years go on, you sort of, become broader and broader with your entry. So that's essentially the rationale for it. But you're absolutely right that people with lower levels than that are still at higher risk.
Great. Well, thank you so much. Got a couple of questions. I want to go to Dr. Andrew Choi, who's one of our cardiologists who's been taking over a leadership role in our lipid program. And Dr. Choi, I think you had a couple of questions you wanted to ask.
Yeah, hi, Dr. Donahue. Great to meet you. And one disclosure is I do collaborate very closely with Ron Blankstein at your institution. So one of my questions is definitely influenced by that. I think the first one is just a broad one for all the clinicians that are here. It is fundamentally now, should every patient, even in a primary prevention setting, now be screened or checked for Lp(a), or should it be targeted? And in which you really nicely highlighted, and I congratulate this fantastic talk, highlighted that first part of the talk.
For the question, I mean, so many societies now are sort of becoming more and more unified in terms of saying that people should all be screened. Everyone should have at least one value, Lp(a) value checked in their lifetime. That being said, I don't think it's being done, right? I mean, we can't take a quick poll on this call, but I'm guessing that only a handful of people, who are attending today's lectures have actually had their Lp(a) checked. I don't know what mine is, So yes, I think that the data support screening because I think we would be more aggressive with risk factor modification for those individuals with high levels. In particular, I've now been seeing people with extremely high levels. And they have developed very early onset of athero. So I think if we have the opportunity to change that trajectory, it does make sense to do.
Right. My second question is around the role of plaque progression. So you showed the Jack paper. It was what Kaiser and Mark Dweck that published it. And one note, Dr. Nick Nurmomed, who's an imaging research scholar with us at GW, was also co-author on that.
Okay.
And so just, so Nick's on, so he's from the Netherlands. Just a question on that, and if you see this idea of plaque, quantitative plaque analysis as a feasible kind of endpoint, you're really designing and implementing these fantastic trials. But when you're looking at on the phase 2 side for new drug development, is that something that you also foresee as kind of a direction in this field, or do you think will be kind of more limited?
Absolutely. I mean, there's tremendous enthusiasm for using coronary CTA or other types of direct imaging of plaques in order to have a meaningful surrogate endpoint in phase 2 development. I'm actually the PI for a small phase 2 that is using coronary CTA as its primary outcome. This is an anti-inflammatory therapeutic. And I think in particular for drugs such as anti-inflammatory therapeutics, we really don't know what else to look at. What is considered to be a meaningful surrogate in phase 2 development that gives somebody confidence that you might be ultimately changing the course of somebody's disease. So yes, I wholeheartedly support coronary CTA as a surrogate outcome and gaining early insight. In fact, we're hoping to still maybe get a coronary CTA sub-study of some kind for these Lp(a) lowering drugs as well.
Yeah, I'm sure Ron is also helping with that as well.
Yeah.
And I'm sure Dr. Choi would be very happy to help as well if you're interested. A couple questions in the chat from Dr. Zaidi, Dr. Catalnati, Dr. Unama around insurance coverage for Lp(a) in general, and specifically in the absence of kind of strong family history or other factors.
Yeah, now my understanding is that it is now covered by basically all insurers to check it at least once. I was also recently giving a talk in Canada and was told that in Canada it's also covered in every province there as well. So I think that given that a lot of the guidelines stand behind measuring at least once, the support, the reimbursement is there as well. If anybody knows whether I'm incorrect on that, please feel free to mention it, but that's my understanding.
And Dr. Moore comments, not Medicare in some cases, so he may be seeing that. I have to say here, at least in the DC area, I order a lot of Lp(a), and I have not gotten either rejection notices or comments from patients about it not being covered. But that doesn't mean certainly that's not happening. And Dr. Moore asked, what about focusing on getting hsCRP less than 1 with lifestyle and high-risk patients?
Yeah, no, absolutely. As we were thinking about that concept of dual goals, right? Achieving low LDL and low CRP, and low Lp(a). Of course, one thinks of C-reactive protein as well, because that is sort of a similar concept that has been discussed too. The thing that's a little bit different, I guess I would offer just 2 comments on that, is that one, CRP is an important marker of inflammation, but we don't necessarily think that CRP in and of itself is directly causal in that pathway. And many of the same therapies that we use to lower LDL cholesterol are basically the same strategies we use to lower CRP. Ultimately you end up sort of intensifying statin therapy as a strategy to lower both LDL and CRP, whereas it's a little bit trickier for Lp(a), where again, the levels are not lowered by statin therapy. So that's why, they might work on slightly different, along different axes in terms of, how we might think about mitigating risk factors for one versus the other.
Great, well, thank you. Comment from Dr. Martin, who previously led our lipid program, and she makes the comment that they have not specifically studied outcomes with niacin and Lp(a) lowering. That was something that she commonly, and I know many people commonly use in the past. And then also I a question from Dr. Jayanthi. How is it that statins increase LP little a, but taking statins increases diabetes risk along with lowering LP little a? And she says, you touched on it, but cannot grasp the explanation. So maybe you could clarify a little bit the role of statins with LP little a and what the thoughts are around the diabetes risk.
Yeah, no, they're all good questions. So I enjoy sort of addressing all of these. In regards to the first piece about niacin, yeah, no, I think the point is well taken. You know, we have studies that have studied niacin in general, but not specifically for use of niacin in those individuals with high Lp(a) concentrations. So, you know, we don't yet really have robust data for use of niacin in general, but I completely take the point that it hasn't been specifically studied in the high Lp(a) individual. The challenge, though, I think, is that we still think that we probably need to see a larger reduction in Lp(a) than what is offered with niacin therapy alone. So that I think is the challenge. And then, you know, why do statins raise Lp(a)? You know, there are many different theories that have been thrown around. Similarly, you know, why do the PCSK9 inhibitors lower Lp(a)? You know, again, because there's so many different theories that have been put forward, I don't know that I can necessarily hang my hat on just one to tell you with confidence what the mechanism is. It is independent of LDL cholesterol. Obviously, in the setting of statin use, that might be apparent since we know that statins are effective for lowering LDL cholesterol. So it is through independent pathways. There have been thoughts that it might be related to the PCSK9 protein. The diabetes part, again, it appears to be probably a different path for statins, perhaps causing an increased risk of diabetes, and Lp(a) also being at low levels, increasing risk of diabetes. Those appear to be different concepts. And again, I can't offer sort of firm insight as to why. In fact, reverse causality has been raised by some, where they've said, you know, with different levels of insulin resistance, that that might force down levels of Lp(a). But I think that the Mendelian randomization data overall support the idea that it's not a reverse causal relationship, but in fact, that for whatever reason, low Lp(a) might increase diabetes risk. Certainly, if anybody has any insights who's on the call, I welcome any further thoughts.
Well, thank you. And I know we didn't get to all the questions. I do want to, for the last question, hand it off to Dr. Frame.
Thank you. I appreciate that. And I'm actually going to tie into some comments that have been in the chat. So you mentioned that lifestyle doesn't really move Lp(a), but that also CRP is an interaction with Lp(a). So we know that, you know, like a whole food plant-based diet, physical activity, the basic tenets of lifestyle medicine are really effective at lowering CRP. So what role does that play here? Is it something we should be focusing on, or is that more effective for the other risk factors beyond Lp(a)?
Yeah, I mean, you're asking somebody who's a huge whole food plant-based proponent. So yes, you know, there is actually at least one study suggesting that adherence to a whole food plant-based diet can reduce Lp(a) concentrations. And that was a small trial, but nonetheless showed a sort of significant impact. So I do believe that there is potential there in terms of being able to modify risk. Certainly, we know that even if it doesn't change your Lp(a) concentration, that the cleaner your diet, that overall that can certainly translate into lower risk of cardiovascular events. So I would certainly encourage anyone to try to, you know, reduce their risk through that method. You know, and CRP being more of a barometer of inflammation, I think there it you know, since that's something, CRP is more environmentally influenced, whereas Lp(a) is more genetically determined. I think that that's part of the stubbornness of changing its values.
Great. Well, Dr. O'Donoghue, thank you so much for both the work that you're doing as well as presenting to us. Thank you, Dr. Frame, for your partnership in the GW Biomedical Cross-Disciplinary Seminary Series, and everyone for joining. So thank you so much.
Thanks for having me.